Hello and welcome. Come on, let's go. All right. So let's start with the second part of cardiovascular then. Let's start talking a little bit about blood vessels and we'll move forward with a little bit about blood as well. Now here when we go through and we talk about blood vessels, first thing I'd like you guys to know that is that blood vessels, they're sometimes compared to a system of pipes. They're sometimes compared to a system of pipes with blood circulating in them. Now, we'll see that is true just to an extent. That's true just to an extent because, unlike rigid pipes, blood vessels are dynamic structures. They pulsate, constrict, relax, and even proliferate, multiply in quantity. Now, so they're basically a delivery system. The heart is the pump, blood vessels are the delivery route you could think of, and then the medium is going to be the blood that's going to be passing through. So this is a delivery system of basically dynamic structures that are going to, you'll see, begin and end at the heart. They'll begin and end at the heart. So when we talk about arteries, I want you to think of the arteries as blood vessels that carry blood away from the heart. They're going to carry blood away from the heart. Now, they're going to carry oxygenated blood. You've probably learned and you've probably studied. However, in our pulmonary circulation and the umbilical vessels of the fetus, it's not going to be true. In the pulmonary circulation, okay, coming back, you can see we've got veins on the way to the lungs. You've got arteries. So those pulmonary arteries are not carrying oxygenated blood, they have oxygen poor blood. Same thing you'll see with the fetus then. Now when we talk capillaries, the second blood vessel type, capillaries now we'll see are going to contact our tissue cells. They will contact our tissue cells and they're going to directly serve our cellular needs. So when you talk about the exchange occurs and our tissues need oxygen and they need to dispose of CO2, where does all that happen? Well, this is the blood vessels where that happens at. So these are the blood vessels that are going to be, you can see, in contact with tissue cells, and they're going to directly serve cellular needs. Cellular needs. And when we talk then third blood vessel type, those will be our veins. When we talk veins, I want you to know veins as blood vessels that carry blood towards the heart. And again, you can't say they're going to carry oxygen poor blood because when you talk pulmonary circulation, you see the pulmonary veins are going to be responsible for bringing oxygen rich blood from the lungs to the left atria of the heart. And you're going to have oxygen rich blood when you're talking fetal circulation. If you remember the ligamentum teres, which was coming from the falciform ligament, which was dividing up the right and the left lobes of the liver, right? That is the fetal umbilical vein remnant, and it's responsible for bringing in oxygen-rich blood from the placenta. So here then when we move through, let's go through the actual structure of our blood vessels. Let's talk about the structure of our blood vessels. Now, when we talk about the structure of our blood vessels are going to have a lumen. The lumen is going to be the central blood-containing space. It'll be the central blood-containing space. Now, let's go through. You can see there's going to be three walls in the arteries and also in the veins. And those three walls, if you recall from anatomy, are going to be called the tunica intima, tunica media, and the tunica externa, basically layers, three different layers. When we talk capillaries made up of endothelium, and they have a sparse basal lamina there, right? That makes sense because this is where we said the exchange of materials is going to occur. So when we're trying to have the exchange of materials to occur, we don't want to have a big, thick layer there. So here, when we're actually passing blood through from one area to another, we've got thicker layers there. And we even see veins. When we talk veins in anatomy, you probably saw the thinnest veins. When you talk veins, veins, we have different types as well. When you talk smallest veins, they're going to be quite thin, and even white blood cells are able to pass through and so forth. You have diapedesis of these cells being basically exhibited there. So here you can actually see the blood vessel structure. Let's see, that's the best picture. Yeah. So here, when we look at the blood vessel structure, we can appreciate now. Let me just this window. Now, when we talk blood vessel structure, here we can see we've got an artery and we've got a vein, and then we've got capillary here, and then here we've got an artery and a vein underneath the microscope. So here, when we talk artery and vein, we've got the three different tunics. The tunica intima. Think of intima, intimate contact with blood, or internal. So now that tunica intima, you learn anatomy, endothelium. When you talk endothelium, you have simple squamous epithelium. That's what you see right inside of there. Right, in relation to serous membranes, we called it mesothelium, simple squamous epithelia there as well. Okay, so nothing different. And then blood vessels inside the heart, we call it endocardium. Same thing we have there as well. And then beneath that, you can see a little bit of a subendothelial layer there, providing protection to that endothelium there. And then beneath that, we can see then we move into the internal elastic membrane. And then the tunica media. Tunica media, now you can see artery and the vein. So look at the vein, endothelium, same thing. One thing special in the veins is these valves you can appreciate there. We don't have them in the arteries, and we don't need them in the arteries because the way blood moves through the arteries is going to be totally different than the way blood moves through the veins, right? You learned that in anatomy there as well, so we'll revisit that and we'll check that out there also. And then you can see again subendothelial layer, and then in the internal and external elastic laminae membranes, basically you can see right inside of here. That's going to be then in relation to the rest of these layers. You can appreciate that as we move through. The main thing we have in the media is the muscle, smooth muscle layer, right? And then look at the difference in size of the muscle here in the arteries. It's much thicker compared to the veins, and again, that's because of the way blood moves in the arteries compared to the veins. And then last, you have the externa, collagen fibers, right? Vasa vasorum out there as well. Vasa vasorum, if you recall from anatomy as well, blood vessels of the blood vessels. I teach in anatomy, we don't have vasa vasorum beneath the renal arteries in humans. We're predisposed then to triple A's. Abdominal aortic aneurysms is what that's associated more with. I believe dogs do have vasa vasorum beneath the renal arteries, and they don't have to worry about that. Somebody told me, one of my teachers told me, I don't know how true that is. I gotta check that out in relation to doggies. So here then, when we go through, we talk capillaries. Then capillaries, we can appreciate then just that endothelium with this scant basement membrane you've got there. Again, that's adapted for diffusion and movement of particles across basically the walls of that blood vessel there. All right, let's move through then. Let's talk about how blood is moving through then. So blood leaves the heart and it leaves into an artery, right? Whether you're talking right side or left side, blood moves from the heart into an artery. And then from the artery, if you're talking right side, obviously it's going to go into the lungs then. And if we're talking left side, we're moving into from arteries into successively smaller arteries, elastic arteries, conducting vessels, and then muscular arteries, and then even smaller arteries, arterioles, and then eventually two capillaries, where the exchange will take place, and then blood will be routed into the venules, from the venules, the smallest veins, and then into venules, and then large veins, and then back to the heart. And then here, if we're talking pulmonary circulation, right, blood leaves, if we're talking the right side, blood leaves the heart into the pulmonary artery. Pulmonary artery, then it goes into the pulmonary trunk, and then pulmonary arteries, and then into the lungs, and then from the lungs it moves into the pulmonary veins, and then basically makes its way back into the heart. You can see there as well. So Here you've got the lymphatic system also associated with, you can see these capillaries there as well. It's all interspersed, intermingled with those. The lymphatic capillaries are going to be interspersed amongst those blood capillaries. So here then, let's talk physiology of circulation. Let's look at some terms here. I want you guys to know, in order to sustain life, blood has to be kept circulating. Blood has to be kept circulating. I want you to know that the heart is a pump. Okay, I've mentioned that a few times. The heart is a pump. The arteries are pressure reservoirs. They are pressure reservoirs and conduits. And conduits, you can think of pipes or channels or tubes. The arterioles then are resistance vessels. They are resistance vessels. Basically, they are blood vessels that convert high pressure. They're blood vessels that are going to convert high pressure, pulsatile, arterial blood flow into low pressure, non-pulsatile blood flow at the pre-capillary sphincters. And they control distribution. The capillaries are exchange sites. And the veins, they are conduits. They're conduits and they function as blood reservoirs. They say sometimes up to about 65% of our total blood supply can be found hanging out in the veins. Now let's look at these few terms here. I want you guys, we'll do a little introduction to blood flow, blood pressure, and resistance. First, we need to understand these three physiologically important terms and then examine how these factors relate to the physiology of blood circulation. So first, let's talk blood flow. Now, when we talk blood flow is basically the volume of blood flowing through a vessel. The volume of blood flowing through a vessel or through an organ or through the entire circulation in a given period. So blood flow through a vessel, an organ, or the entire circulation in a given period. Flow can vary. Blood flow may vary widely. And flow is going to be related to the organ's needs. And it will be related to the organ's needs. And blood flow is going to be measured as millimeters over minutes. Next term is blood pressure. Now, what does blood pressure mean? Blood pressure is describing basically the force that's exerted on a vessel's wall. Blood pressure is talking about the force that's exerted on the blood vessel's wall. Well, what's exerting pressure on the blood vessel's wall? It's the blood that's found inside. So it's the force exerted on a vessel wall by the contained blood. And blood pressure is expressed as millimeters over mercury. So it's expressed, you can see here, in millimeters over mercury. Unless stated otherwise, Okay? Unless stated otherwise, the term blood pressure, it means systemic arterial blood pressure in the largest arteries near the heart. Okay, otherwise, if it's somewhere else, that will be noted. So, unless stated otherwise, the term blood pressure means systemic arterial blood pressure in the largest arteries near the heart. Near the heart. Because sometimes we have patients where we have to use the femoral. And we'll mention blood pressure in the femoral artery. You have to make note of that. Next, then, here, I want you to know it is our pressure gradient. Blood pressure is our pressure gradient. It's the difference. Okay, it's going to be our pressure gradient, which is the difference in blood pressure within the vascular system. That's going to provide the driving force that's going to keep blood moving. So it's that pressure gradient, that pressure difference, that's going to be the driving force. Just like we saw with the heart. In the heart, it was that pressure difference that, again, kept everything moving there. It opened and closed the valves. And if those valves didn't open and close properly, the heart's not working properly. So here when we talk now, I want you to know it's going to be our pressure gradient, the difference in blood pressure within the vascular system. That's going to provide the driving force. That's going to keep blood moving. And blood is always going to be moving from an area of higher pressure to an area of lower pressure. It's going to be moving from an area of higher pressure to an area of lower pressure through the body. Third term then is going to be resistance. Resistance is opposition to flow. It's opposition to flow. When we talk resistance, resistance you'll see is measured. It's going to be measured as the amount of friction. It's measured as the amount of friction that blood is going to encounter. So it's the amount of friction that blood encounters as it passes through the vessels. As it passes through the vessels. There are three important sources of resistance that blood is going to encounter. Or basically that this flowing blood can encounter, we can say. The first form of resistance is going to be changes to the blood itself, and that's going to be blood viscosity. Now, when we talk blood viscosity, this doesn't happen too frequently. We'll see that. This is dealing with the thickness of blood. So we're talking blood viscosity. Blood viscosity is talking about the thickness or the stickiness of a fluid. Now, in polycythemia, where you have too many red blood cells, blood viscosity is increased. Blood viscosity is going to be increased, as is resistance. In anemia where you can have a red cell count that's decreased, this basically rendering the blood less viscous, also decreasing peripheral resistance. The second factor there we could see is blood vessel length. Simple, straightforward. First with resistance. Now when we talk resistance, okay, if we increase resistance, this increases blood pressure. So if we increase resistance, we increase blood pressure. So blood viscosity, increased viscosity, increases resistance, increases pressure. Blood vessel length. The longer the vessels, the greater the resistance that's going to be encountered. Right? Check our blood pressure. Compare that to the blood pressure in a baby. Babies, the blood vessel length isn't as great as ours is, and their blood pressure is less than ours are. So, blood vessel length, the relationship between, again, blood vessel length and resistance is straightforward. The longer the vessel, the greater the resistance. Third, then, is blood vessel diameter. Diameter changes are going to be more frequent. They're more frequent than the other two, than blood vessel length. Right? Our blood vessel length isn't going to change unless, again, our demand increases now in adulthood. So when we talk blood vessel diameter, diameter changes are more frequent than the other two and significantly alter blood resistance. And they alter resistance. Resistance varies with blood vessel radius. This means that if the radius of a blood vessel is doubled, the resistance drops. So again, if the radius of a vessel is doubled, the resistance drops. Next, then let's talk and let's check out blood pressure. So here, throughout the entire circulation, starting from the aorta, moving through the arteries and the arterioles, and then the capillaries, the venules, veins, and then the vena cava, and to the right side of the heart. And then passing through the pulmonary circulation, right? And then coming back, we're picking it up from the systemic circulation. That's what we're really concerned with. Here you can see a few different things. We're going to go through, we're going to talk about, we're going to check out. You can see here first, right off of this picture, it's pulsatile blood flow. When it passes through the aorta, arteries, and then the arterioles, becomes less. And pressure, look, it significantly drops as well. Right? You got pressure here on this side, and the vessel on this side. Pressure, when it comes down into the vena cava, is very low. And so the right side versus the left side, pressure is a total big difference. And I gave you guys the pressure as well, I believe, in pulmonary circulation and systemic circulation there as well. So here, I'd like you guys to know then, let's talk systemic circulation. Now, when we talk systemic circulation, here are a couple of things. I'd like you guys to know, first thing, you can see basically blood flow there. We saw that out. I saw that there. I want you guys to know, any fluid driven by a pump, any fluid that's driven by a pump through a circuit of closed channels operates under pressure. And the nearer the fluid is to the pump, the closer the fluid is to the pump, the greater the pressure exerted on the fluid. Blood flows through the vessels, I told you, along a pressure gradient, always moving from an area of higher pressure to an area of lower pressure. The pumping action of the heart generates blood flow. Pressure results now when flow is opposed by the resistance. So here we can see it shows us systemic blood pressure is highest in the aorta, and it declines throughout the pathway to reach close to zero in that right atrium. Zero basically in that right atrium. So let's talk arterial blood pressure. Arterial blood pressure reflects two factors. Number one, how much the elastic arteries close to the heart can be stretched. So it's talking to us about their compliance or their dispensability. Number two, arterial blood pressure reflects the volume of blood forced into them at any time. So again, in this figure, we can see blood flow is being depicted in all the vessels, and here it's being depicted in greater detail with pressure. So we talk blood pressure. Blood pressure we can see is pulsatile. It rises and it falls. It's not constant. Now, when the left ventricle contracts and expels blood into the aorta, it communicates or it imparts kinetic energy to the blood, which stretches the elastic aorta. And aortic pressure, you can see here, reaches its peak. That peak pressure is what we call systolic pressure. Systolic pressure. So when we talk systolic pressure, I want you to know systolic pressure is the peak pressure. Is the peak pressure exerted on the aorta as the left ventricle contracts and expels blood into the aorta. This pressure, as we can see here, this pressure averages, in a healthy adult, it averages about 120 millimeters of mercury of pressure. Hence, where we get 120 over 80, right? So there's the 120. Now, the next reading, the diastolic pressure, is the minimum pressure in that aorta. Now, it's when the walls of the aorta recoil. It's when the walls of the aorta recoil, maintaining just enough pressure to keep blood moving forward. Aortic pressure drops. It drops to its lowest level, and that's the diastolic pressure. And that's the diastolic pressure. And it averages about 70 to 80 millimeters of mercury. Our elastic arteries are going to operate as auxiliary pumps. Our elastic arteries are going to operate as auxiliary pumps to keep blood circulating when the heart itself is in diastole, or when the heart is relaxing. The next term you have here is pulse pressure. Now, when we talk pulse pressure is going to be the difference between the systolic and diastolic pressures. It's felt as a pulse. It's felt as a pulse in an artery during systole. It's felt as a pulse in an artery during systole and averages about 40 millimeters of mercury of pressure. Averages about 40 millimeters of mercury of pressure. So again, the difference between systolic and diastolic pressures. Systolic and diastolic. Next is mean arterial pressure. Mean arterial pressure. Now, when we talk mean arterial pressure, or MAP, is the pressure that propels the blood to the tissues. It's the pressure that propels blood to the tissues. Mean arterial pressure is going to be equal to diastolic pressure plus pulse pressure divided by 3. So mean arterial pressure is equal to 80 millimeters of mercury, which was our diastolic pressure, plus pulse pressure over 3. Pulse pressure was 40 millimeters of mercury over 3, giving us a mean arterial pressure of 93 millimeters of mercury. So here, let's write that out. Is going to be equal to, I'll abbreviate diastolic pressure as dP, plus, we said pulse pressure over 3. So diastolic pressure, 80, average, plus 40 over 3. So we said 93 millimeters of mercury. Okay. Next then, let's talk capillary pressure. Again, I won't give you probably anything to do with here. I'm saving it for filtration pressure. Okay, I want you to be able to, if I ask you it in multiple choice form, you should be able to answer it there. Same thing with the pulse pressure as well. Okay, so next then let's move to, so we took care of arterial blood pressure. Get out of here. Capillary blood pressure then. Let's talk capillary blood pressure. Capillary blood pressure now, blood pressure in the capillaries is low. It's about 35 millimeters of mercury of pressure when it reaches the capillaries. So blood pressure is in the capillaries is going to be low. It's about 35 millimeters of mercury when it reaches the capillaries, and it drops to about 17. So here you can see we're entering the capillaries, it's about 35 millimeters of mercury. By the time we leave the capillaries, it's about 17 millimeters of mercury of pressure. About 17 millimeters of mercury pressure at the end of the capillary beds. Low pressure in the capillaries is desirable. Low capillary pressures are going to be desirable because of a few different things. Number one, the capillaries are fragile. They're fragile, and high pressure would rupture them. Okay, number two, most capillaries are extremely permeable, and thus the low capillary pressure forces solute-containing fluids out of the bloodstream, right, and into the interstitial space. Venous blood pressure then. When we talk venous blood pressure, you'll see unlike arterial pressure, which is pulsatile basically, which pulsates with each contraction of the left ventricle, venous blood pressure is steady. It's steady and changes very little during the cardiac cycle. Pressures in the veins is going to be about 15 millimeters of mercury. Pressure averages about 15 millimeters of mercury in the veins. Blood circulates from the veins to the heart mainly due to 3 functional adaptations. So again, blood circulates from the veins to the heart mainly due to 3 functional adaptations. Number 1, you have what we call your muscular pumps. When we talk muscular pump is talking to us about how skeletal muscles activity is going to help pump blood forward. So here what happens is the placement of our veins. The placement of our veins are placed in between skeletal muscle. So our skeletal muscles are surrounded veins are going to be surrounded by skeletal muscle. When the skeletal muscle contracts, this pushes blood forward. It pushes blood, kind of like it's milking blood, forward to or towards the heart. Second then is your respiratory pump. Now, respiratory pump, what happens here is you see you got pressure changes. Pressure is going to change in the ventral body cavity due to breathing. As we inhale, abdominal pressure increases, squeezing the local veins and forcing blood towards the heart. Third then is going to be sympathetic venoconstriction. This third adaptation, it deals, you can see, with the layer of smooth muscle. It's going to deal with the layer of smooth muscle that's going to be found around the veins that constricts under sympathetic control, causing venous volume to be reduced and blood to be pushed forward towards the heart. And then here, you'll also look at different types of basically dilators and different medications, different classes of medications that we could give as well to patients. Let's talk about then, here you can see the muscular pumps and the placement of the veins and how they're going to allow blood to move forward. And you can see this adaptation we talked about. Valves are going to ensure that blood stays moving forward. It doesn't trickle back. Right? And then we have, when these valves stop working properly, this condition called varicose veins. So let's talk maintaining blood pressure. Now when we talk maintaining blood pressure, you can see there's three important components. There are three important components. And these three important components are going to maintain blood pressure. And these three important components are going to include, number one, you can see we've got cardiac output. So resistance, cardiac output, peripheral resistance, and blood volume, the three factors there. So here now when we go through and we talk about maintaining blood pressure, so here I want you to know these three important components there. Now when we go through these three important components, cardiac output, peripheral resistance, and blood volume, blood pressure is going to vary. Blood pressure is going to vary directly with cardiac output, resistance, and blood volume. So blood pressure is going to vary directly with cardiac output, resistance, and blood volume. Blood pressure maintenance. Blood pressure maintenance is done via short-term regulation and via long-term regulation. Short-term regulation is done by the nervous system and by blood-borne hormones. Which alter blood pressure, which are going to alter blood pressure by changing peripheral resistance. So that means resistance in the arteries. So by changing peripheral resistance and cardiac output. Our long-term regulation alters blood volume via the kidneys. So here we can see our three terms: cardiac output, peripheral resistance, and blood volume. Let's go through each of these. Now, when we go through and we talk about cardiac output we can see is equal to stroke volume times heart rate. We've seen that. It's about 5 to about 5 to 5.5, 5.5 liters a minute. Right? We've gone through that. We've checked that out. And then during stress, you can see the Cardiovascular Center increases heart rate and stroke volume via sympathetic stimulation. That causes end systolic volume decreases, causes it to decrease, and mean arterial pressure increases. So here, when we go through and we talk now cardiac output, okay, here you can see what exercise is basically going to do to cardiac output. And then here we could see how increase in heart rate due to decreased blood pressure, decreased blood pressure activates these cardiac centers in the medulla. And here you can see what they're going to do is eventually help to increase heart rate and increase stroke volume, which are going to help increase cardiac output. So when we talk cardiac output, you can see cardiac output is going to be then one of our main factors influencing blood pressure. Okay? So here then we could move down and we can talk about short-term regulation then. Let's get into short-term regulation. So I told you short-term regulation is going to be accomplished via neuro and hormonal components. And then we talk long-term we said by altering blood volume. So let's go through and let's talk then short-term neural components. When we talk short-term neural components, I want you guys to know short-term neural components are going to alter both cardiac output and peripheral resistance. They will alter cardiac output and peripheral resistance. Most neural controls operate via baroreceptors, chemoreceptors, and higher brain centers. So, baroreceptors, chemoreceptors, and higher brain centers. We also have our Cardiovascular Center that's going to be found in relation to the Cardiovascular Center. We're going to be looking at there as well. So when we talk Cardiovascular Center, the Cardiovascular Center is going to be at the medulla oblongata, and it consists of several neurons. It's going to consist of several neurons that control blood pressure by altering cardiac output and blood vessel diameter. This center, it consists of the cardioacceleratory center and the cardioinhibitory center, and as we mentioned before, the vasomotor center that will be responsible for controlling the diameter of our blood vessels. Let's talk baroreceptors. When we talk baroreceptors, I want you guys to know baroreceptors are going to be pressure sensitive mechanoreceptors. They are pressure sensitive mechanoreceptors, and they respond to changes in arterial pressure and stretch. They will respond to changes in arterial pressure and stretch. Baroreceptors are located in the carotid sinus, which are basically dilations in the arteries. And these baroreceptors that are located in the carotid sinus, they protect the blood supply to your brain. Now, there's also going to be baroreceptors in the aortic arch. And they will be responsible for maintaining pressure in your systemic circuit. That will be the baroreceptors in your aortic arch. And then also in the walls of nearly every large artery in the neck and thorax. They're also going to be found in the walls of nearly every large artery in the neck and thorax. Now, when stimulated by stretching, they're going to send rapid streams of impulses. They're going to send rapid streams of impulses to the brain, which responds by decreasing blood pressure. Which will respond by decreasing blood pressure. The function of rapidly responding baroreceptors is to protect the circulation against short-term or acute changes in blood pressure, such as those that occur when we change position or we change posture. So here we could see if we have pressure changes, right? The stimulus here is an increase in blood pressure. The arterial blood pressure rises above normal ranges. And what this does is the baroreceptors in the carotid sinuses and the aortic arch are going to get stimulated. They then, you can see, are going to increase impulses. Those impulses are going to increase from the baroreceptors, and they're going to stimulate the cardioinhibitory center and inhibit cardioacceleratory center and inhibit the vasomotor center. So here you can see decreased sympathetic impulses to the heart causes decreased heart rate, decrease in contractility, and decrease in cardiac output. And also at the same time, a decreased rate of vasomotor impulses allows vasodilation, causing a decrease in resistance. So decrease in cardiac output, decrease in resistance, returns blood pressure to homeostatic ranges. And then the opposite as well. Now if blood pressure goes low, if you have a decrease in blood pressure, arterial blood pressure falls below a normal range, baroreceptors in the carotid sinus and the aortic arch are inhibited now. They're going to send basically, now you're not sending impulses there. What happens is you have decreased impulses coming in from baroreceptors. And when you have these decrease in impulses coming in, this is going to activate the cardioacceleratory center and inhibit cardioinhibitory center and stimulate the vasomotor center. And here you can see increasing resistance by causing a constriction and increasing sympathetic impulses to the heart, all increasing cardiac output, increasing resistance, helping to return blood pressure to its normal range. We also have chemoreceptors. When we talk chemoreceptors, they're going to be found located in the aortic arch. They're found located in the aortic arch and the large arteries of the neck. Now, chemoreceptors, they detect changes in carbon dioxide levels, pH, and oxygen content. If CO2 levels increase, or if pH decreases, or if our oxygen content decreases. So these three different stimuli, chemoreceptors send impulses to the cardioacceleratory center. They'll send impulses to the cardioacceleratory center, which increases cardiac output. These chemoreceptors, they also activate the vasomotor center. Which causes vasoconstriction. Now, when we talk short-term mechanisms, we could see influence of higher brain centers. We could see how the medulla is involved there, and then the hypothalamus and the cerebral cortex can also be involved there. Now, when we talk hormonal controls, hormones actually help regulate blood pressure both in short-term regulation via changes in resistance and also in long-term via changes in blood volume. That's where your essay comes in. So let's talk adrenomedulla hormones. When we talk adrenal medulla hormones, we're talking norepinephrine and epinephrine. Norepinephrine and epinephrine increase sympathetic output, and they increase cardiac output and vasoconstriction. Angiotensinogen, let's get into talking about this whole ROS system. So let's start with angiotensinogen. Angiotensinogen is going to come from the liver. Angiotensinogen is going to get converted to angiotensin 1, and that'll happen if blood pressure is low or blood volume is low. Angiotensinogen 1 gets converted to angiotensinogen gets converted to angiotensin 1 thanks to renin. Renin is an enzyme that comes from the kidneys. Renin converts angiotensinogen to angiotensin 1. Angiotensin 1 then gets converted to angiotensin 2 thanks to ACE, angiotensin converting enzyme. ACE comes from the endothelial cells of our lungs. It's important you understand that because in certain patients that will be taking a certain class of medications for hypertension called ACE inhibitors, they develop a cough as a side effect sometimes. So here now, when blood pressure or volume are low, the kidneys will release renin. Renin acts like an enzyme generating angiotensin 2, which stimulates vasoconstriction, causing a rise in systemic blood pressure. It also stimulates the release of aldosterone and ADH, antidiuretic hormone, which act in long-term regulation of blood pressure. First hormone I want to mention here is ANP, atrial natriuretic peptide. It's produced by the atria of the heart. It causes blood volume and pressure to decline. It antagonizes aldosterone and causes the kidneys to excrete more sodium and water from the body, reducing blood volume. It also causes vasodilation. Antidiuretic hormone, we'll see when we talk antidiuretic hormone is going to stimulate the kidneys to conserve water. It will stimulate the kidneys to conserve water. It's produced by the hypothalamus. And it helps restore arterial pressure by causing intense vasoconstriction in situations where pressure falls to dangerously low levels, as what happens in hemorrhage. We'll see it's involved in long-term regulation more. So let's talk then long-term regulation. So right when we talked long-term regulation now, okay, here we could see when we talk long-term regulation. Now, first we'll look at renal mechanisms. This system, it controls blood pressure by renal mechanisms which alter blood volume. Now, an increase in blood volume results in an increase in blood pressure. Okay, I want you to understand that. An increase in blood volume results in an increase in blood pressure. I always tell you guys the fastest way for me to increase your blood pressure, besides saying pop quiz, okay, is for me to insert an IV. If I insert an IV, okay, I'm increasing your blood volume, which will increase blood pressure. It's like your water hose, your garden hose. If you want to increase the pressure there, what do? You increase the water volume, or what do? You mess with the diameter, right? Increasing resistance, right? You can't go and make the water thick or thin. I mean, that's harder to do, but you can mess with the diameter of the vessel or the hose, or the quantity of water, which can increase the pressure there as well. So when we talk blood, okay, volume, an increase in blood volume is going to result in an increase in blood pressure. And a decrease in blood volume results in a decrease in blood pressure. Now the kidneys act both directly and indirectly to regulate arterial pressure. Let's look at the direct renal mechanisms. Here, the kidneys either excrete to decrease, or the kidneys conserve to increase fluids to alter then blood pressure. If blood volume or pressure rise, the rate at which fluids filter from the bloodstream to the kidneys, okay, so if blood volume or blood pressure rises, the rate at which fluids filter from the bloodstream to the kidneys tubules speeds up. As a result, pressure and volume. As a result, pressure and volume drop. When blood pressure or blood volume is low, water is conserved. Water is conserved and it's returned to the bloodstream. And what does that do? That helps blood pressure to rise. So you can see that right inside of here. If you have a decrease in arterial pressure, this is via the direct renal mechanisms. This is your essay part. So this is the slide I told you would have to go through and understand. So here, you could see if you have a decrease in arterial pressure, you're going to have a decrease in the filtration by the kidneys. That's going to lead to a decrease in urine formation. So you're not removing as much. What does that do? That increases blood volume. What do we say? What happens with blood volume increases? Increases arterial pressure. Let's look at the opposite. If you have an increase, we said, in arterial pressure, that'll increase the filtration by the kidneys. That'll increase the urine formation. That'll help decrease blood volume. And that'll help then decrease mean arterial pressure. So the opposite. Now, indirect renal mechanisms, where the kidneys are going to regulate blood pressure indirectly via the Ross system, the renin, angiotensin, aldosterone system. So here we have Ross system, renin, angiotensin, aldosterone system. So it starts with renin being released by the kidneys when arterial blood pressure declines. So arterial blood pressure declines, inhibits, this sends this is not sending signals now through the baroreceptors. Baroreceptors are inhibited. This increases sympathetic nervous system activity, which increases, you could see there then, Renin release from the kidneys. When arterial blood pressure decreases, renin converts angiotensinogen, a protein that's made by the liver, to angiotensin 1, I told you. Then angiotensin converting enzyme comes from, I told you, the endothelial cells of the lungs. So for this essay, you have to be able to explain all of this here that I'm telling you. Angiotensin 1 gets converted to angiotensin 2 thanks to ACE. Angiotensin 2 acts in 4 ways to stabilize blood pressure. You have to be able to explain this. Here you could see, number 1, angiotensin 2 is going to make its way over to the adrenal cortex. Knocking on the adrenal cortex's door, saying, adrenal cortex, release big Al, aldosterone. So adrenal cortex is going to release aldosterone. And I'm 100% sure you remember from which layer of the cortex, right? You got to know that stuff. I told you guys the deeper it gets, the sweeter it gets. So we're on the outside. Salt, right? The deeper it gets, the sweeter it gets with the adrenal glands. You got sodium on the outside, then glucose, sex hormones, okay? Whatever works, you got to remember. So aldosterone gets released. Aldosterone then is going to increase sodium reabsorption by the kidneys. Increasing sodium reabsorption, water follows. Increasing water increases blood pressure. Oh, here we go down here. So increasing sodium reabsorption. Oh, I didn't know it was all there. Increasing sodium reabsorption by the kidneys increases water reabsorption by the kidneys, which increases blood volume, which increases mean arterial pressure. Right under my nose, I didn't see that. This lockdown is exam being postponed. This is craziness. Angiotensin 2 also increases ADH release by the posterior pituitary, if you recall. We talked about that there. And then the ADH is going to increase water reabsorption by the kidneys, right? Antidiuretic hormone, so we're not releasing any fluid from the body. Antidiuretic. Increasing blood volume, increasing arterial pressure. Angiotensin 2 also increases the thirst center via the hypothalamus, which increases water intake, which increases blood volume, which increases blood pressure. Angiotensin 2 also causes vasoconstriction, which increases peripheral resistance, which increases mean arterial pressure. So for that essay, you have to be able to explain everything, as we did here, and this Ross system in full-on detail. You got to make this Ross system your best friend. So we could give, you're going to learn about this in nursing school as well. You're going to see here, and we have ACE inhibitors, one class of drugs we can give, or we have ARBs, angiotensin receptor blockers. So if these angiotensin receptor blockers, right, angiotensin receptor blockers go and block the receptors on which angiotensin is going to work, we're not going to see that increase. Okay, so that's another class of drugs you'll give. Usually you'll change from ACE inhibitors to those if your patient develops a cough or whatever the case may be for your patient. That's what you have to look at. Next in here, let's move and let's talk about clinical monitoring of circulatory efficiency. So here when we go through and we talk about clinical monitoring of circulatory efficiency, this can be assessed by taking a pulse. So here we're able to go through and check out what we've got here. Same thing here as well. Short term we went through baroreceptor reflexes. So make sure you get that down. Angiotensin's functions. We've got all this here as well. Okay, so we could see here increase of activity by muscular pumps, respiratory pumps. Eventually, all of these factors are going to help increase mean arterial pressure is what we're getting into. So if you look at blood vessel size, right, resistance increases. We saw that there. Dehydration, leaving us with a high hematocrit then. That increases blood viscosity. But again, how often does that happen? Not that much. Still going to increase resistance, which is going to increase pressure. And then here you can see increasing vasomotor tone, bloodborne chemicals, epinephrine, norepinephrine, ADH, angiotensin 2, decreasing blood vessel diameter, increasing resistance, helping increase blood pressure. And then here we can see stressors, exercise trauma, increasing temperature, fluid loss, hemorrhage, excessive sweating, or decreased release of ANP, again, or activation of these pumps, all going to eventually help increase mean arterial pressure. So when we go through, we talk about measuring circulatory efficiency. We could do that a few different ways. Taking a pulse, measuring blood pressure, okay, there as well are a couple of more common ways. Now here when we talk about taking a pulse, first I'd like you to know, is going to be a part of your vital signs. The pulse, blood pressure reading, and temperature and respiratory rate. 4 components that make up your vital signs. So we talk about pulse. A pulse is a pressure wave. It's a pressure wave that is transmitted through the arterial tree. It's an alternating expansion and recoiling. Alternating expansion and recoiling of the arteries during each cardiac cycle. Measuring blood pressure is another way. Now we talk measuring blood pressure. Blood pressure is measured indirectly in the brachial artery of the arm. And we can do this via the oscillatory method. The oscillatory method is going to use a blood pressure cuff and a sphygmomanometer. I'll explain that in a few seconds. Here, when we talk taking a pulse, I'd like you to know, and you can even check your own pulses here, or those of your family members. Here you can see now, in class, we would go through and we would check superficial temporal, facial artery, common carotid, brachial artery, radial artery. You would do your own femoral, and same thing you can do here. Popliteal, then you would do to your partners. Posterior tibial, and then also the dorsalis pedis. So here you can see 1, 2, 3, 4, 5, 6, 7, 8, 9 palpable pulses that you have to know about. You have to know these in the nursing program as well. So do yourself a favor and get them down here. Now when we talk measuring blood pressure using the oscillatory method, now here when we talk oscillatory method, I told you is going to use the sphygmo and the stethoscope. Now here, what happens is we listen for the Korsakoff sounds. We listen for the Korsakoff sounds. And we listen for those Korsakoff sounds with the stethoscope. So here what happens is we will get our blood pressure cuff and we'll place this blood pressure cuff over the brachial artery, which is going to be found running through the arm. So the blood pressure cuff is going to be placed on this bicep. And here what happens is then we'll close the valve on the blood pressure cuff, right? Righty-tighty, lefty-loosey. Generally speaking, just learning to use that valve is a pain. So I always tell my students, make sure you play with that valve for 5 minutes. Turn it all the way tight, and then make it loose. Make it loose, turn it tight, make it loose, turn it tight. And you have to learn to be able to control that even very slowly. Sometimes you don't want it to go fast. So here then what you do is once you figure that out, you'll place that sphygmomanometer over the biceps. And here then what we're going to do is you have your gauge here, and we'll inflate that blood pressure cuff to about 180 millimeters of mercury. But what you're going to do is you're going to look at your patient's history and kind of determine what you'll go to there. If you don't have a history, then you'll use 180 or 200 as your kind of guide there. And if you start hearing the Korsakoff sounds right away, then you know you got to deflate this and you got to go up a little bit higher. Then you could use the other arm and kind of try it again there. So here then what you'll do is once you've placed the sphygmomanometer over the patient's arm, you'll inflate the sphygmo to about 200 with about 200 millimeters of mercury of pressure. And then your stethoscope, you want to place it where this red dot is at. And there you see the brachial arteries running through here. Now here what's happening is when we inflate the blood pressure cuff, what we're doing is we're reducing the flow of blood through that brachial artery. Okay, we're basically reducing that blood flow through the brachial artery. Now what we're going to do is when we release that pressure slowly, when we start to release the pressure slowly, now we want to be able to listen to the sounds and gauge the pressure and monitor the pressure and record that pressure. So here now, when we start to release the pressure off of that artery, at the same time we're listening, it's an oscillatory method, you're going to be listening for the Korsakoff sounds. Now, the first sound you're going to be hearing is they're basically like this. They're tapping sounds. I'm going to try to create it here on the table. It's kind of like a tapping sound like that. So here what happens is you're going to be listening for two sounds. The first sound we're going to be seeing is the systolic sound that we're going to be hearing is the systolic sound. The second sound is the diastolic sound, the diastolic pressure and the systolic pressure. So the first sound you're going to hear is around 120 millimeters of mercury. And this is when the first sound occurs. So when the sound first appears, that's the number you're going to record right off the gauge. And this is basically when blood starts to spurt through the artery. That's the sound we're listening for. Then second sound we're going to listen for is the diastolic pressure. This is normally around 80 millimeters of mercury. And this is the pressure when sounds disappear. And they're disappearing because the artery is no longer constricted. So blood is flowing freely through the vessel. So you have your systolic and diastolic pressures. We can also have alterations in blood pressure. Alterations in blood pressure can occur, and these conditions can be known as hyper and hypotension. Hyper and hypotension, here when we talk hypotension, hypotension is going to be basically low blood pressure. It's low blood pressure, and hypotension can be dangerous if blood pressure is too low. The reason why is because then you have decreased tissue perfusion. The tissues don't get enough blood flow through them. Hypertension is chronically elevated blood pressure, and it can be dangerous because it can cause blood vessels to tear. Now, variations in blood pressure can happen due to posture changes. If we were in the lab, I would tell you, and you can do this at home as well, to check your patient's blood pressure when they're lying down versus when they're standing up. Gravity is going to make a difference. And even you can try in between sitting down. Physical exertion, emotional upset, and also fever can cause changes. Age, sex, weight, race, mood, posture, again, may cause blood pressure to vary. So hypertension, high blood pressure that's sustained around 140/90 or higher. Now we also have prehypertension. If the value is elevated but not yet in a hypertensive range. So the doctor will let you know, hey, you've got prehypertension, and it could persist and it could become hypertension if you don't start to treat it now. And then hypotension, we'll see there. So hypertension, prolonged hypertension, again, heart failure, right? Because that pressure is going to be increased pressure inside that heart as well. Vascular disease, renal failure, because now those glomeruli are going to have high pressure inside of there. And stroke, because now higher pressure inside the arteries can cause the blood vessels to tear. So that's why blood pressure, high blood pressure, hypertension is not good. The heart also must work harder, causing the myocardium and the heart eventually to enlarge, and it weakens, becoming flabby. And then this whole process also accelerates atherosclerosis there as well. Now, primary or essential hypertension makes up about 90% of hypertensive conditions. There's no underlying cause that's been really identified there. Risk factors include heredity, very important there, diet, obesity, age, diabetes, stress, and even smoking. No cure, but it can be controlled. Right, various ways to control it. Secondary hypertension, it's less common. However, it's due to identifiable disorders, including either obstructed arteries, kidney disease, or even endocrine disorders. And then treatment is going to focus on correcting the underlying cause. And then we've got hypotension. We mentioned there as well. Now, blood flow through body tissues, tissue perfusion. Blood flows through body tissues, and tissue perfusion is involved in number one, the delivery of oxygen and nutrients to the body's tissues, and the removal of waste from tissue cells. Second, tissue perfusion we'll see is involved with gas exchange in the lungs. So tissue perfusion is very important for gas exchange in the lungs. Number three, when we talk about the absorption of nutrients from the digestive tract, it's going to be important when we deal with the absorption of nutrients from the digestive tract. And then fourth, also in urine formation of the kidneys, very important. You'll see that the rate of blood flow to each tissue and organ is almost exactly the right amount to provide for proper function. When the body is at rest, the brain receives about 13% of total blood flow. The heart, about 4%. The kidneys, about 20%. Abdominal organs, about 24%. And skeletal muscle, which makes up almost half of the body's mass, receives about 20% of total blood flow. During exercise, blood flow increases to skeletal muscles, and flow to the kidneys and digestive organs declines, obviously. And you can see that here in this picture as well. Now, when we move through and we talk about the velocity of blood flow, when we talk about the velocity of blood flow, the velocity changes. The velocity changes as blood flows through the systemic circulation. The velocity of blood is fastest in the aorta and slowest in the capillaries. Next is the term autoregulation. Autoregulation is an automatic adjustment of blood flow to each tissue in proportion to its requirements. Organs regulate their own blood flow by varying the resistance of their arterioles, and they do that a couple of different ways. They do that via metabolic controls and myogenic controls. So when we talk about blood flow through the capillaries, blood flow through a capillary is slow and intermittent, and capillaries differ in their leakiness or permeability. Liver capillaries allow even proteins to pass freely, whereas brain capillaries are impermeable to most substances. So when we look at the capillary exchange of respiratory gases and nutrients, it's going to be done by diffusion, and you have 4 different routes. First, I'd like you to know lipid-soluble molecules such as respiratory gases, they diffuse through the lipid bilayer of the endothelial cells. Number 2, when we talk about small water-soluble solutes like amino acids and sugars, they pass through the fluid-filled intercellular capillary clefts or through the fenestrations. And then number 4, so 3 was fenestration, then number 4, large molecules like proteins are transported in penocytic vesicles or caveolae. So when we talk about fluid movement, fluid is forced out of the capillaries through various ways at the arterial end of the capillary bed, but most of it returns to the bloodstream at the venous end. So here you can see all four passageways that we've just mentioned. So the direction. Now the direction and the amount of flow across the capillary walls reflects the balance between two dynamic and opposing forces. Those are hydrostatic and colloid osmotic pressures. Hydrostatic pressures. Hydrostatic pressure is the force exerted by a fluid pressing against a wall. In capillaries, hydrostatic pressure is the same as capillary blood pressure, as if I was to say capillary blood pressure, which again is the pressure that's exerted by the blood onto the capillaries' walls. Capillary hydrostatic pressure, we can see is abbreviated here, tends to force fluids through capillary walls. It's a process called filtration, leaving behind cells and most proteins. The blood pressure in the capillaries varies. It varies from 35 millimeters of mercury of pressure at the arterial end of the capillary bed to, we said, about 17 millimeters of mercury of pressure at the venous end. Now, this pressure is opposed by the interstitial fluid hydrostatic pressure, which is going to be acting outside the capillary and pushing fluid in. Oh, we don't have to worry because that pressure is usually zero. Next pressure you need to know about is colloid osmotic pressure. This is where I told you have to pay attention and make sure you're able to do this equation. Colloid osmotic pressure, the force opposing hydrostatic pressure, it is created by large, non-diffusible molecules such as plasma proteins that are unable to cross the capillary wall. So these molecules, they draw or they pull water towards themselves. There is an abundant amount of plasma proteins in capillary blood. You learned in anatomy primarily albumin. So they develop a pressure that's called capillary colloid osmotic pressure, or we can also refer to it as oncotic pressure, and it's about 26 millimeters of mercury. The interstitial fluid also contains few proteins, so the pressure there is called colloid osmotic pressure. However, it's lower. It's around 0.1 to about 5 millimeters of mercury. Now let's look at the interaction between the hydrostatic and osmotic pressures. This is where we then talk about what we refer to as net filtration pressure. Now, net filtration pressure comprises all forces acting on the capillary bed to figure out a certain pressure, and then for you to figure out in which direction the fluid is moving. Is the water moving in or is it moving out? So when we talk hydrostatic osmotic pressure interactions, here in this figure, okay, here it goes into it all into certain detail. Here's the arterial end, here's the venule end. Okay, here we could look at it all together. Now here, we will look at calculating net filtration pressure, something you have to know and you have to be able to do. Not once, but at least twice on that exam. Now we talk net filtration pressure. It considers all the forces I told you acting at the capillary bed. Net filtration is occurring at the arterial end of the capillary. A negative value for net filtration pressure at the venous end indicates that the fluid is moving into the capillary. Reabsorption is occurring. So as you can see, fluid flow is out of the circulation at the arterial end, and fluid flow is into circulation at the venous end. Now here, let's look at first the arterial end. We look at the arterial end. Net filtration pressure is going to be equal to, you can see here, hydrostatic pressure. There's a few different ways to do this. I don't care how you do it, as long as you come up with the right answer, as I always say. Okay, here they're getting and adding these numbers and then eventually subtracting them from one another. But again, there's many different ways that you could do that. As long as you come up with the right answer is all I care about on the day of that exam. So here we can see they're getting hydrostatic pressure in the capillary, adding it to the oncotic pressure of the interstitial fluid. So those are like pressures. If you look at the hydrostatic pressure of the capillary is causing fluid to move out. And if we look at oncotic pressure of the interstitial fluid, it's doing the same thing. So these are two forces that are going to be causing fluid to move out of the capillary and enter the interstitial fluid. And then look at here, the hydrostatic pressure is much bigger, it's thicker. It's being described by this thicker arrow there. 35 millimeters of mercury. Here, 1 millimeter of mercury, and you can see it's not that thick. So we get those two numbers and we add those two numbers and we get a number. Here we could see 35 plus 1. 35 plus 1, right, we've got there is 36. We're going to subtract that from the other two numbers, which are going to be now hydrostatic pressure of the interstitial fluid and the oncotic pressure of the capillary. Again, look at the way those forces are acting. 26 millimeters of mercury of oncotic pressure in the capillary. Why? Because there's proteins, a lot of proteins in here. Any in here? No, because none should be able to leak out. So we have zero pressure here. So here now you could see we had 36. Here we have 26. So we subtract the two. We have net filtration pressure of 10 millimeters of mercury of pressure. It's a positive number. I told you positive number is indicating a net outward pressure. So as a result, fluid moves from the capillary into the interstitial space. Versus the venule end. Look at the venule end. We'll do the same exact problem there. So here we have 17 plus 1 minus 0 plus 26. We have an answer of minus 8, negative 8 millimeters of mercury. So that's indicating to us a net filtration pressure into the capillary. That's why you have things that move. You can see that's why you have fluids that move out then here at the arterial end, and that's indicated by those arrows. And then fluid basically moving in the venule end, and then eventually into the venule. So that 100% guaranteed. I'm telling you, you have two questions, and each question is a two-part question because one part will be in figure out the number, and then the second one will be in which direction is this moving. So two questions for just one of these, and we'll have probably total of 4 questions total. Any questions? Email me. Let me know whatever you need.